going to speak in the next 20 minutes about CIED infections because these are becoming quite common these days as more and more implanters which less and less experience implant devices. And we are getting quite sick patients which have been managed inappropriately after wasting a lot of money. Some of them would have wasted at least about 5 to 6 lakh rupees before they come to us, and they are literally without money to undergo a lead extraction or a device reimplantation. So what I'm going to do is I'm going to put two parts together. One is the device infection P, how to avoid it, because prevention is better than cure. The second is afterwards, what should you do and how should you approach to a patient with device infection. Now, we have to realize that in the West, where we have data, the overall incidence is about 0.5 to 2.2%. However, in our center, where we do about 600 to 700 implants continuously, we have been doing it for more than about 12 years now, our infection rates are very low because we follow a very strict protocol, which I'll share with you. The incidence of infection is about 2 to 5 fold higher when you do a device replacement rather than in a patient who undergoes a de novo implantation. And in patients who develop a cardiac implantable device infection or device-related infection, it is also called as, the mortality is quite high if they are not treated properly. The in-hospital mortality can be about 2 to 15%, and about 6 months later, it can be 4 to 30%, and at 1 year, it can be 9 to 35%. And most importantly, it's a very, very expensive treatment because not only do you have to extract the lead, where the sheath itself costs about 2.5 lakh rupees in our center, plus the lead locking stylet costs about 75,000. So for one lead, you require one stylet. So if you have multiple leads, you require multiple stylets, plus the ICD, plus the antibiotics, plus the stay, plus the reimplantation is a huge cost. So if you have a patient with infection, please refer early, not to do multiple admission. And we have to realize majority of the CIED infection requires complete explantation of the whole system. You can't leave anything behind. Now, there are certain risk factors for device-related infection, which could be grouped into 3 groups, which are the perioperative factors, the device factors, and the host factors. The perioperative factors would involve use of temporary pacemakers, especially if it is a long-standing temporary pacemaker which has been there, lack of antibiotic prophylaxis, prolonged operative time, which usually happens with an inexperienced operator, and most importantly, if the operator does less than 30 implants a year, it has been shown that they have a very high risk of infection. And post-operative pocket hematoma and superficial implants, especially in children as well as older people, results in device erosion and infection. And device factors could be CRT, ICD, which are quite complex, take longer procedure times, abdominal implants and epicardial leads have higher infection rates. While as the host factors, so please, if you have a central venous catheter, please get rid of it as early as possible. Tell your anesthetist or anybody to have as less catheters as possible. If there is a distance focus of infection like a diabetic foot or something, please do not do anything until the infection is under control. Do not advise any invasive procedures around the time of CIED implant. And patients who are diabetic, CKD, and older age have a higher risk of implants. And even those who are on steroids or immunosuppression and malignancy have higher risk of infections. Also, patients who are on anticoagulants, if they are not managed very well, they can develop hematoma and infections. Now, having said that, the pathogenesis can happen. It can happen in various ways. That is, the infection can happen prior to implantation because when a person is handling the device in the lab, when he's handing it over to you in the device, it can get infected. Or in the operating theater, which is the cath lab usually is not very well ventilated, and many a times people don't even wear the caps and masks and enter and exit out. Some of the labs where I have seen even they enter it with their shoes on from the roadside. So these are the places which is likely to increase the risk of infection. During the implantation, a poor technique and a long procedure can increase the risk of infection. And a surgical site infection can occur due to the patient's own skin contamination. There can be hematogenous seeding from a distant site, and also contamination can occur after skin erosion. So all erosions literally mean that the device is infected. Very rarely, there can be a problem during manufacturing, and this results in what is called as a cluster infection with a very unusual organism. So we could divide prevention. I would call this as prevention because these are the most important things that you should do when you're doing, which we follow. And I expect that the students who are there, the DMD students, I'm going to spend a little time there. This is not for the experienced people who would already be doing. So these are pre-procedure measures. So first is just confirm that the patient really requires a cardiac implantable device. If it does not require, many times you try to do this device, they get infected. Delay the implantation in patients with infection. So they should be at least fever-free for at least 24 to 48 hours with normal counts. Avoid a temporary pacemaker or a central venous line. If there are central venous line, remove it preferably before you implant the device and put in a peripheral IV line. You avoid pocket hematoma, so please do not bridge with heparin. If the patient is on a vitamin K antagonist, it is our preference to do it on an INR of 1.8 to 2. So what we do is we start doing an INR every day, withholding the vitamin K antagonist. When it is about 1.8 to 2, we go ahead and do it. There is no problem. Avoid peri-procedural low molecular weight heparin. If you give it, you are assured of a hematoma in the pocket, and then that hematoma gets infected. Perform the procedure in a completely sterile environment. Do not allow anybody to enter without a cap and mask. See that this thing is completely sterile. Hair removal should preferably be with the electrical clippers. So avoid using razors because this can cause micro damage to the skin, which increases the risk of infection. And you can even do the electrical clipping only if it is interfering with the site where you're going to do. Just clip it very minimally using an electrical clipper with a disposable, tip. So try not to abrade the skin with razors, and you can even do the removal of hair just before you take the patient. Antibiotic prophylaxis should preferably be cefazolin or flucloxacillin 1 to 2 grams 60 minutes before the procedure, or if you're giving IV vancomycin, which is 1 to 1.5 grams 90 to 120 minutes before the time of incision. So this is very important. Now, there are certain peri-procedural measures which I am going to highlight on. Routine pre-surgical washing with an antimicrobial agent can be given. So you can ask them to take a povidone iodine wash, or you can ask them to take an alcoholic chlorhexidine wash and come. Skin preparation is preferably with alcoholic chlorhexidine rather than povidone iodine. So I'm telling this because with povidone iodine, the risk of infection is much higher than with alcoholic chlorhexidine. What we do is when the patient comes on the table, we just spray the area with chlorhexidine solution and allow it to dry before we start draping the patient. Before we start painting the patient, we do it once more with chlorhexidine before we drape the patient. Allow sufficient time to dry. So don't put it on a don't put everything on a wet thing. And then use an adhesive incised drape. So we always use an iodine impregnated incised drape to cover the area so that the skin does not cause infection. Now, in case the operator performs the prepping and draping, remove the gloves. And if you are going to put a temporary pacemaker from the groin, you de-scrub completely and then re-scrub again. If you are wearing a double glove, remove the double glove after you have prepped and draped. Preferably use a powder-free glove. I use a powder-free glove because I'm allergic to talcum, so I use it automatically. It reduces the risk of infection. So it's very important to follow this during the procedure. Please do not puncture from the skin for venous access because this makes the lead very superficial for erosion. A proper incision is a must, and there should be no hesitant cuts. and minimize tissue damage. Your incision and your handling of tissue should be very good and achieve good hemostasis. And do not open the hardware and keep it on the table. So you just have to, suppose you want to put in the lead, open the lead from the packet just before you put it in. Do not leave the device open to air for a long time on your table. During PG replacement, avoid capsulectomy. So you should not take out the capsule because it causes a lot of bleeding and hematoma. And during replacement, avoid cutting leads. The pocket is very important. It is extremely important that the pocket be made medially. What I see is pocket is made very laterally and it causes erosion. So the pocket should be made between the fascia and the muscle. So do not make the prepectoral pocket in the fat. So you should lift the fascia from the pectoralis major muscle and make a pocket. In a thin individuals, such as older people or very thin individuals or in children, go for a subpectoral pocket. If you can't do it, call the surgeon to make it for you. And make a pocket medially. I'm telling this again and again. Most of the erosions happen on the lateral aspect because the pockets have been made laterally. Do not make the pocket right at the beginning and put your gauze into it. It is quite likely it will cause infection. So the lesser the time you keep the wound open to air, the lesser the chances of infection. It is it's my training to teach, and I have been trained that way in the Royal Melbourne to create pocket right at the end, just before we put in the device. Local installation of antibiotics is not recommended these days. And in patients who are high risk, like those patients who are CKD or diabetes or risk of infection is high, you can use antibiotic envelope, which is available. It is not usually for all patients that you should use it, because if you want to prevent one infection, you have to use 10 of these envelopes, which are quite expensive. Now, sutures, avoid braided sutures. Do not use sutures such as the silk to do the wound closure in layers. So use monofilament sutures to close the wound. And if you're doing this, silk sutures, it is quite likely, more likely that they can get infected. Now, having said that, there are certain post-operative measures which you should use. You should avoid using long post-operative antibiotic therapy, because whatever infection is going to happen is happening during the time of implant and then not again after that. And pressure dressing for 24 hours should be fine. Dress for about 2 to 10 days. What we use nowadays is we use what is known as Mepilex, which is a soft silicone, dressing, which can be left there for about 5 days. So we just put Mepilex in and send the patient home. So I want to tell the patients about wound care, not to get it, dirty. Then reconsider the case. Suppose you find that there is a sort of hematoma, avoid needling it, reconsider 10 times before you do something, and refrain from doing the hematoma drainage. Some people try to squeeze it, some people try to press it. Please do not do it. Unless there is a wound dehiscence or it is extremely tense, do not try to evacuate the hematoma. So these are certain measures which you use. For the diagnosis of device-related infection, you will have to use your clinical criteria, which is the local inflammation, discharge, fever, and embolic phenomena, especially if you have vertebral osteomyelitis and discitis in a patient who has got a device. Think of a device-related infection. Identification of the organism is very important, so use blood cultures, at least 2 samples. It can also be done for isolation of the microorganisms can be done from the tissue and fluid cultures. And also when we extract the lead, we take the cultures from the distal, proximal lead fragments, vegetation, and the generator pocket tissue so that we isolate it. Imaging will come to this. So we use transthoracic echocardiography, transesophageal echocardiography, and in fact, intracardiac echocardiography, if you have it in your lab, it's very useful. In those patients whom we are in doubt, we use this F18FD PET CT, or we do not have this, the WPC SPECT is also very sensitive in identifying the site of infection. So we can categorize the device-related infection into 8 groups, depending on the clinical scenario. It could be superficial incisional infection, which is just a local infection. It could be isolated pocket infection, pocket erosion. Whenever there is an erosion, it almost always means that the device and the whole system is infected. It could be just bacteremia without nothing being shown elsewhere. So positive blood cultures. It could be pocket infection with bacteremia. Endocarditis using Duke's criteria, you can identify it with or without pocket infection. And sometimes you can have occult bacteremia. So there is no other source of bacteremia, but the patient has fever, and when you extract the device, it resolves. This again indicates a device-related infection. So this is some of the pictures you can see here. You can hardly see anything, but there is a infection in the pocket. You can see erosions, and as I've told you, erosions almost always happens on the very lateral aspect. So these are the various phases of device infection, and you can see that this patient has had a cut lead, and it is pouring out from here, and he has got a very big, endocarditis lesion there. So this is the diagnostic algorithm which I'm going to share with you, either with a positive blood culture or a negative culture. We have pocket clinically positive, pocket clinically negative. We use the transthoracic and transesophageal echocardiography, and optional is use of PET FTG, which we have been using more frequently these days to identify infections. So if it's pocket negative, but there is a high clinical suspicion, use transthoracic transesophageal echocardiography with FDG. If the pocket is clinically not very good, but you think that there is an infection, again, one needs to think of and extracting this device. Now, how do we go about treating these patients? Once we have identified that the patient has got a device-related infection, identify whether it's just a local infection. If it's just a superficial incisional infection, one can do a conservative treatment, just by giving antibiotics. But if there is a definite or a possible CIED infection, it requires complete removal of the device and all the leads and every hardware. These are the various imaging that we need to sort of consider when we are doing this: the transthoracic, the transesophageal echo, the CT scan, the PET FDG, and the chest X-rays and fluoroscopy. So if you have a superficial infection, the antibiotic therapy can be used. Depending on what you culture, you can give it for 7 to 10 days. If there is a definite CIED infection, you will have to remove the lead completely. If the blood culture is negative, the antibiotic therapy is usually for about 10 to 14 days. But if there is a systemic infection, you need to give 4 to 6 weeks after we remove the device. So when we do the lead remove, when we do lead removal procedure, it could either be a lead explant procedure. Lead explant procedure is something where we do not use specialized tools like the lead locking stylet or the cutting tools. We can use only the stylet, and this is usually possible in leads which have been having an indwell time of probably less than a year, usually about 6 months to 8 months, where they come in very early. But if it has been more than a year, do not try to tug on the lead, because the lead just fragments. So if you just give a gentle tug, if it doesn't come out, leave it alone, send it to a center which can do lead extraction. Do not put, a lot of, tension on the lead. So removal procedure could be transvenous from the superior approach or from the femoral approach. It could be an open surgical approach also, or it could be a hybrid procedure where we can do transvenous plus open surgical, depending on what we find. So we use various tools such as the mechanical cutting rotating tools, or we use the snares, or we can use the lasers which are available these days. The patients usually done in the EP laboratory or in a hybrid lab under GA. So don't do it under local anesthesia. Active surgical standby is very essential. You have to have the CPB right in place, because if you tear the superior vena cava, you just have about 5 minutes time to save the patient. You have to have a continuous TE throughout the procedure with continuous SpO2. We prep the whole chest and abdomen just like we do a bypass, and we keep the bridge balloon as standby if it's available. Then we open the pocket, dissect it out carefully, remove the sutures right up to the entry site, put an implantation, try to pull it out, unscrew the lead and try to gently pull it out. If manual traction doesn't pull it out, then we go on to the extraction procedure. That was the explant procedure. Now we get to the extraction procedure. If we try to do a lead simple gentle traction, it doesn't come out, Then we extract the lead using one of the mechanical or laser cutting sheets. If there are residual fragments, we use snares to remove it, either from the femoral or jugular approach. And sometimes, very occasionally, if small pieces are left, especially in infection, we have to get everything out. We may use a surgical extraction if parts are left behind. So this is how we approach it, and this is how it's already been shown to you. This is a laser extraction, the one which you can see a bevel here. This is a laser tool which we are using here. The previous one was a mechanical tool. So this is from the left side. That the one which we showed previously was from the right side. So this is how the lead looks like. Many times you get biopsies and you get tissues here. So this is the extracted lead. And when you do a replacement, no part of the removed CIED system should be reimplanted. So many times I get patients being told by the referring physician, ask them to put back the old device because it's got battery. Please do not do it, because again you can get it infected, because there is a biofilm on the top of these devices which harbor the microorganisms. The lead has to be on the opposite side. If a patient is pacemaker dependent, we use what is known as temporary permanent pacemaker, where we use a permanent pacemaker and an external active fixation lead to keep the patient mobile for up to 10 to 14 or even up to 21 days till the cultures are negative. So, ladies and gentlemen, CIED infections are increasing with increasing number of implants being done. Proper implantation techniques probably avoids or decreases the number of infections. The indications for lead extractions are well defined, but it is not for a novice. Please let me tell you, it is not for a novice, and please do not cut the leads. Well-proven extraction techniques are available. Complications are very infrequent if it is done properly, and mortality is uncommon with experienced centers. So thank you all for a patient hearing.